Thank you very much. So, yeah, I am. First of all, I suppose I need to tell you kind of why you possibly want to listen. Maybe you're just here because it's cold outside, I don't know. So, yeah, I am a consultant community paediatrician. I'm based up the road, 15-minute cycle away at the Mary Sheridan Centre in Elephant. Chair of the ADHD strategy group, which we have set up in Lambeth. I'm co-chair of the neurodevelopmental conditions special interest group. I put that up partly, if you don't know about ACAM, it's probably a good idea that you know about ACAM, the association, if you're interested in this kind of thing. If you are interested in child and adolescent mental health, it's an excellent, happens to be fairly local organisation, which is actually frankly dominated by people from the Maudsley. You ought to kind of get involved, because actually I think particularly if you're a student it's extremely easy and cheap to join. I do also work a little bit with the Royal College of Paediatrics. I'm their Officer for Health Improvement, within which I am the clinical lead for neurodevelopmental conditions. So I have both a policy and also a clinical role in neurodevelopmental conditions. I put up this list and I thought this is a bit of a boast fest. It sort of reminds me a little bit of this. I don't know how many of you remember this film, but so I ought to also add, I'd forgotten how good it is actually, I also add that I'm a terrible singer, almost incapable of climbing stairs without tripping on them, and so disorganised it's a miracle I'm here. Anyway, that said, what are neurodevelopmental conditions? Briefly, I'm sure you all know, or at least think you know, but I think it's important to just be clear on what we're talking about. Yes, we are talking about ADHD. I'm sure you all know what ADHD stands for and what it is, and we're talking about autistic spectrum disorders, autism, whatever you want to call it, it doesn't really matter. But it's also important to mention that those aren't the only two neurodevelopmental conditions. To be a neurodevelopmental condition, for me, is a sort of brain-based difference which causes a functional difficulty which is detectable in developmental life. It's a kind of plucked from the air definition, really. But as well as the ADHD, which is to do with your control of your brain, you're controlling your own brain, how well you can do it, and autistic spectrum disorder, which is broadly about how you understand other people and the uncertainties of life. There's also developmental coordination disorder, which is to do with how you plan and execute movements in order to function within your everyday world. And this is the one that my wife is convinced that I have. And there's also, additionally, developmental language disorder, which is a new word essentially for language impairment, specific language impairment, whatever you used to call it. But has very much come into the neurodevelopmental conditions fold and has a very similar way of diagnosing to all the other neurodevelopmental conditions. Learning disability, you really could argue very strongly, is a neurodevelopmental condition, which is just a sort of a more global impairment of the cognition. So it's really important that we think about what these things are and their commonalities. There are some others that people could argue for. People could argue for Tourette's. I think it's a very strong argument that Tourette's and tic disorders are also neurodevelopmental in nature. And you could argue all sorts of things. I have heard people argue that anxiety disorders are neurodevelopmental disorders. But anyway, let's move on. The thing about them is, on the one hand, I'm sure you're all aware of the kind of debate around psychiatric diagnosis that is seemingly never ending and often conducted in tedious length on social media. But actually, as mental health diagnoses go, and I have my kind of critical moments when it comes to psychiatric diagnoses. I've never quite understood intermittent explosive disorder being a good idea, and paediatric bipolar is another one that I've always thought was a little dodgy. But these ones I thought are relatively solid. We have very well established diagnostic schemes which are internationally agreed. We have some pretty good evidence of brain-based differences. I want to use that term very precisely, differences. So you look at the brain of someone with autism and you look at the brain of someone without autism, you will find differences. Whether that means that whether that actually means that we definitely need to make a diagnosis is another question entirely. That said, one of the most convincing things for me is how much heritability there is if you look at these diagnostic categories, and it's almost the same for something like autism and something like ADHD. It's often thought that autism is very genetic and ADHD is very much less, but actually a lot of the work seems to indicate that they're comparable, at least. I mean, different people come out with slightly different results. That's what's research. I think almost the most important thing about these conditions is that there's lots of evidence for things that work in these populations. Because actually, in a way, and one of my kind of take-homes is always, well, if you can't do anything about it, why are you bothering? Why are you bothering to kind of go through all these assessments and stuff? In practice, of course, in a research setting, by all means, go for it. But actually, in clinical practice, if you're not actually going to help, why are you mucking around, essentially? But on the other hand, these are not conditions which are straightforward. It's not like doing an EEG and diagnosing a particular form of epilepsy, or doing a biopsy and finding out what kind of cancer you're dealing with. These are conditions without biomarkers. Much as we have all the scan data, none of them, as far as I can see, is a convincing biomarker for any diagnostic work. And also they are spectrum conditions. Now this means different things to different people, and people sometimes, there's another way of understanding it, but the way I understand it is that they are conditions that mark out a portion of the normal variation of human existence, and that portion which is at the extreme of it and which causes problems. Does that make sense? So it's an extreme of human existence which is causing some problems. And so there is inevitably a kind of grey area between diagnosable and, I don't use the word normal, I ban it from my clinic, typical. Typical behaviour, typical abilities, whatever, however you want to put it. So inevitably, because of the lack of biomarkers, there is subjectivity in assessments, and a lot of the time, the stuff we spend hours and hours on, such as triangulating different views from different people, for instance, from schools, from home, and from your own observations, and also using validated instruments, are really just to kind of mitigate some of the subjectivity, and also doing hundreds of these assessments so you know what you're doing. These are all really to mitigate any kind of subjectivity that you're dealing with. And still it's there, it's irreducibly there. If I find a child annoying in clinic, it's probably more likely they'll get a diagnosis rather than I find them charming. It's just inevitable. There is also an alarm button above my desk in my clinic room, and every child who's ever pressed that button during clinic has subsequently received an ADHD diagnosis. So, anyway. But I think that's probably valid, because they're the impulsive ones who go, oh, a button, let's press that. But not all the children who have received an ADHD diagnosis have pressed that button, if you see. There is a role of, so there is particularly in ADHD, but I think probably there should be more in ASD, debate around the role of environmental influences. Not because they're spectrum, well, I'll explain this in a minute, but essentially, because they're spectrum conditions and there is this grey zone, I think environmental influences can really make the difference on kind of borderline cases between diagnosable and non-diagnosable. And so therefore I think there probably should be more attention on environmental influences in autism, and perhaps a little less in ADHD, but still they remain important, and reasons that I will go into. But I think not so much in autism, but I think that will come. But in ADHD, there's a huge debate and a huge concern, particularly about practice in the United States, about overdiagnosis and overtreatment. We have some figures from some poorer districts of some states in the US. There's some really shocking figures about how many boys, particularly, are on ADHD medication in pockets of the United States where people have become very enthusiastic, very over-enthusiastic. So this all happens against the background of what is really a kind of philosophical war around mental health diagnosis and the nature of mental health. I don't really find the war very interesting. I think it becomes a very professional battle of power between psychiatry and psychology, which I'm not interested in, because I'm neither of those things. But I think the two real examples I think this really wages a lot within ADHD, but not so much within autism, although I think you could have the same debate in autism. By the way, if anyone wants to ask a question, stick your hand up now, because there's a lot to get through. So if you look at kids with, let's just talk about ADHD for now. If you look at kids with ADHD, you will always find some other things that are contributing to their difficulties. You will always find, oh, they're a little bit autistic, or they've also got a speech delay, or their hearing's not great, or their family dynamics isn't great, or there was some domestic violence in the family. Incidentally, often because one or more parents have ADHD, and people with ADHD are more prone to violence. Or, you'll find something. And this has led Richard Saul, MD, to write a book which is still the highest ranked search result on Amazon. If you search ADHD on Amazon UK, ADHD does not exist. Because basically he says, well, you can always find something else, so why don't you just ascribe it to that? And that is an argument that is convincing precisely as long as you don't think about it. As soon as you think about it, it falls apart. Because, of course, you could do that with... I mean, the converse of that argument is you could find someone with ADHD about which there is absolutely nothing else remarkable. Well, how can you find anyone about which there is nothing else, about which there is nothing remarkable? If you look deep enough into people, into their backgrounds, into their personalities, into their relationships, you will find something remarkable or something interesting or something that potentially could cause problems in all of us. Just to take one example, people talk a lot about attachment status and whether that is a cause of ADHD-like behaviours. But if you talk about insecure attachment, you're talking about 30% of the population. Well, okay, fine. But how many? Not everyone who's got insecure attachment exhibits ADHD behaviours in the classroom. So I'm not sure. I mean, conversely, it's not valid to say he's got ADHD. His attachment status is entirely irrelevant, because of course it will condition their approach to problem solving, their approach to relationships, their assumptions when they are forming friendships. Those are all important things as a person. They don't necessarily bear on the diagnostic process. But instead of making those kind of, yeah, okay, fine, ceding some ground, saying, oh yeah, all that stuff is important, yeah, and we should really kind of do things in context, the pro-ADHD kind of side of the debate essentially just stick up a load of scans and go, look, how can you say this doesn't exist? And you're like, well, okay. But all you're showing is that a population is different to another population. It doesn't show that there is a clear distinction. It doesn't show that your diagnosis is actually useful. It just shows that people who behave in a particular way have slightly different brains on rather sophisticated brain scanning. You have to get. This is incidentally quite an early result that hasn't been brilliantly replicated, but there is some stuff going on here, of course, that is much more sophisticated and has found some genuine differences. But that doesn't mean that the diagnosis is definitely valid. It doesn't follow in that way. You could find all sorts of differences between me and you, and you and you. It doesn't mean we have to have a diagnosis. Does that make sense? So I sort of reject this turf war, and I kind of go, this is not helpful to anyone. What we need is an understanding which embraces both points of view. That's what I would say. And this is how I'm going to do it. I'm not going to move away from medicine altogether and move away from diagnosis. So let's have a look at banging your heads on doors. Okay? So let's have a look at standard deviation of height. All right? So let's imagine that doors are not designed for, because doors really are designed for massive people. But let's say that all the doors around are now kind of 17th century size of doors. You've got a very old buildings and very low doors. So if you were to look at your height against frequency of banging your head, it would start off very low. And for the first sort of standard deviation or so above the norm, you wouldn't have any problems because the doors would still be okay. And then it would suddenly shoot up. But then there's a point at which even very, very tall people would only hit their head so many times because they get used to it. It's not a great analogy, but you know what I mean. Basically, the world is designed for average people, and the more away from average, you're going to get more problems. But there's a point, the key thing here is that the two things. One is there's a period where there's a range outside the typical where people compensate for their difference. And then there's a decompensation phase, I would say, and then there's a levelling off. And this, I think, is the key to where the idea of diagnosis within spectrum conditions can come in, but also where the grey zone is. Does that make sense? So let's split this and call this ADHD. Classrooms are designed for typical average children. If you're a little bit above average, in terms of how... so the way I think of the ADHD brains is, if you have ADHD, you are like the captain of a ship. You're in the control pod. But things are, you're not really in control. Your brain is hungry. You're not yourself hungry, your brain is hungry, and you can't control that hunger. And it's hungry for stimulation, for movement, for emotion, for reaction, for excitement, for all of those things. And you find it very difficult to control. So if you're a little bit like that, you can compensate. But there's a point at which that becomes problematic. So what I would say then is that this is why there's probably two populations, one up here who are obviously ADHD and one down here who are obviously not. But in the middle, there's these guys who are a not insignificant number. And this guy's up here, you probably would diagnose. These guys down here, I don't know. I genuinely don't know. It depends. But probably I wouldn't. But there's a point at which nobody really knows whether it's diagnosable or not. Is that making sense to everyone? Okay. So there is a genuine grey zone within any spectrum disorder where there's no biomarker. This is what happens, incidentally, if you just change the environment. If, to use our analogy, you make the doors bigger. If you change the parenting environment, you make it more positive. If you change the classroom environment, again, you make it more positive and more understanding. You put interventions in place to help. You get a small but significant improvement after environmental modification. And I think you get that in both autism and ADHD. Now, if you're up here, it doesn't look like much, doesn't it? It doesn't look like a big swing. But if you're this person, if you remain exactly as ADHD as you were before, because this is really your biological position on a spectrum, and this is how much trouble you're being caused, look at what happens to how much trouble you're being caused. It's phenomenal. So for this group of mild to moderate, environmental modification is absolutely the right thing to do. So incidentally, that's one reason why I'm a keen advocate that we don't give kids, unless they're severe, medication for ADHD to start with. Because there's so much you can do. Yeah? Just a simple, almost mathematical reason why it is the right thing to do, and it's the right to do it. And also, another good reason why, if you start treating children down here, you're not going to make a huge amount of difference to them, because they're not that bad anyway.
Max,
hello.
Another question. In the ADHD does not exist. I read it like a year and a half ago.
Yeah.
And I feel like what you just said there is chiming actually with what he was saying.
Yeah.
Is that you should look at the environment, and it might not be that you have to pathologise their behaviour. You just need to modify the environment.
So can I go back to that point? It's a really good point. I mean, certainly you need to modify their environment. I think, just briefly, what he's saying, he's equating making a diagnosis of ADHD with giving medication, and I don't think you have to equate that.
Yeah.
And most of my patients who get ADHD diagnosis do not go onto medication. Because I will go back to that. But within that grey zone, you then get variations of diagnosis, and variations of diagnosis should give us pause for thought, undoubtedly. So this is one of many studies that have been done on birth date and diagnosis. So basically, this is for a birth month where there's a British-like system where the oldest children in the school year will be born in September, and the youngest will be born in August. And there's a really significant rise in the amount of ADHD diagnosed. And that's got to give us pause for thought. That whether or not you get this lifelong diagnosis depends on your birth month. Now, I don't think there's been good evidence for whether there's a similar gradient for autism. I think there's been some preliminary stuff to suggest that there may be a small one, but people are not quite so het up about autism. But I wouldn't be surprised if there's also a little bit of a gradient in autism as well, because these children are less mature. Hello.
Sorry to interrupt. Can you give a good example of when there's been environmental modification, like a trial, that showed improvement in ADHD symptoms?
So the question is not whether you're improving the ADHD symptoms, because if you're doing environmental modification, the aim is not to make the child have less ADHD. The aim is to make the child who has his ADHD symptoms or her ADHD symptoms cope better in their life. And therefore, the trial you've got to look for is all of the trials of parenting intervention in ADHD, all of which show better standard of living, better relationships between children and parents. You look at all of the evidence base around Incredible Years, Triple P, New Forest parenting program. That's what they show. They don't necessarily show a difference in ADHD symptoms. And actually, that's not what they're for. So that's what I would say. And I think it's much more difficult when you look at school, because, frankly, the education system has not got the culture or infrastructure to set up randomised controlled trials in the same way. So we have to rely more on best practice. Does that satisfy? Good. Good question, then. So this is an interesting one from the US. This is the difference in diagnosis across states. So it's really very stark, isn't it? You'd be stretching my knowledge of US states, which I really must get better at a lot.
Where's Delaware?
Exactly, I don't know. But I just want to point out, the one I always point out is the difference between Texas and Louisiana, because I know where they are. And it's a really stark difference. Now, I've seen some really weird explanations for this disparity. One is that these states get more sun. I'm like, it's not exactly like Wigan in Louisiana, is it? Anyway, some of you may not know where Wigan is or Louisiana. But I think it's more plausible that this is to do with legislation. There are certain states where a diagnosis is required for you to get special educational assistance. And these are the states where you get much higher levels of diagnosis and treatment. So children essentially are being given medication more often because otherwise they don't get any special educational assistance at school. And that is something that I am very disturbed by. So let's look at overdiagnosis and why you might do it. So one of the real drivers, I think, for overdiagnosis, and something that we come up against an awful lot, is the idea that you can't get any help unless you've got a diagnosis. And that is challenging because, of course, the NHS runs on a diagnostic, that's my last point really, runs on a diagnostic paradigm. It's very difficult to get assistance if you haven't got a diagnosis to support you. Strictly speaking, education in the UK does not. Education is needs-based. Special educational needs is based on a needs-based system. There is mention of diagnosis in the Special Educational Needs Code of Practice, but nothing should be based on diagnosis, in theory. In practice, that is not the case. There are services which you need to get a diagnosis, particularly of autism, in order to get access to it. If you're trying to get an education, health and care plan, which is essentially the way to get above £6,000 a year for your needs, it's very helpful in effect to get a diagnosis. So there's no doubt there is a pressure to make a diagnosis so that children can get the help that they need. Now, it's very difficult. If you're not sure, well, there might be, but we're not sure, and you've got this pressure, but basically the child will only really cope if they get extra help, and they're not going to get extra help unless you make the diagnosis. What are you going to do? It's difficult. At the same time, and this was an interesting question, why do we pathologise these children? Why don't we just help change the environment? Because parents and the rest of the family and teachers, they will label these children. Whether we label them or not, they will be labelled with something. They'll be labelled with naughty, or they'll be labelled with poorly brought up, or they'll be labelled with single mum, or young mum, or poor attachment, because somebody's read a book somewhere. Sorry, I get that irritated. I don't get irritated by attachment theory, which I think is a brilliant theory, but it's been horribly poorly used and mangled out of all recognition out there in the kind of child care workforce. But bulbing is brilliant. Don't worry about that. But I think the families who come to see me already have a label.
Yeah.
And they may have labelled themselves, their children may have been labelled by their teachers or by their grandmother or everything. So all I'm doing is changing the label to something that I would argue is less stigmatising than you are a young mother. This is someone I saw this morning. She was a young mother. She was a victim of domestic violence. All of these things all of her child's behaviour is being blamed on all these things. But actually, he's got pretty obvious ADHD. As does she, incidentally. As probably her partner, which is relevant. So that's interesting. And I think it is a genuine pressure to remove any suggestion that there's something that the parent has either done, not done. So if the parent has had difficulty with drugs and alcohol, it's a great, well, in some ways there's a let-off that they get a diagnosis, but equally, actually ADHD can be caused by exposure to drugs and alcohol, so it's a bit of a double-edged sword. But generally speaking, parents feel less blamed once they've got a diagnosis, particularly autism. Children who are very controlling and anxious, perhaps when they have had a lot of negative parenting, perhaps with a parent with mental health problems, marital discord, often will end up with a very controlling, not very good communication, and people can be pushed into a diagnosis of autism at around 4 or 5 very easily with these children, because it really absolves the parents of any kind of guilt that they feel about how difficult things have been growing up. And it's something that's difficult to resist, but we have to resist it because these kids are not autistic. They don't have the social communication deficits that we have in autism. But I think increasingly they're getting a diagnosis because it is easier for everybody. Now in the UK and the NHS, the only perverse incentive for the doctor is the doctor feels clever, or the clinician or the psychologist feels clever, but also they can discharge. They resolve this problem and they can move them on. And that is a huge pressure. Of course, in other systems, where there is a pay-by-diagnosis system, there are other financial perverse incentives to diagnose. But in the NHS, there's still a pressure to be the clever person who comes in and solves the problem. And we must remember that we are human and there's such a temptation. I did it this morning. I mean, I think I did it in a robust way, but I went in and went, no, don't worry, this is what's going on. Because I've been, because I am who I am. Fine. But we've got to remember that that's what we're doing, and that we should resist the temptation to just make ourselves feel clever in order to solve the problem and move on. So then then it becomes someone else's problem. That's something we shouldn't do. The other thing, of course, is that increasingly the NHS is built on codes. It's built on coding. Everything needs to be classified. If you have somebody who doesn't fit into a category, you have to more or less discharge them because they're not fitting into a pathway. And that is very difficult because need doesn't fit into pathways. You have children who are extremely needy, who need a lot of support, whose mental health is very difficult to manage, whose behaviour is very difficult to manage, but they don't fit into any of our categories, and so it can be very difficult to obtain a service for them. And that is ethically very unsound. So I think that's another perverse incentive. Why does it matter? I'm sure it's all implicit, but one of the things I think is it can overshadow the other factors. So the child who gets a diagnosis of autism, when in fact what they need is for the family to get some support, for the parents to get some support with their mental health and with their relationship, for them to get parenting support, and for the whole thing, the whole system to be held much better, they won't get that necessarily. They'll get a load of autism-related things. People argue about stigma. I've made the argument that actually neurodevelopmental conditions are not stigmatizing, but other people make the argument that they are. I don't want to tell them that they're wrong, but that's not my experience. So I'll put up. But you will definitely miss other therapeutic avenues if you overdiagnose. I think particularly in ADHD, often actually what you will do is miss other neurodevelopmental problems or other developmental problems, or Richard Saul's book makes the point, if you just diagnose ADHD all the time, you will miss hearing impairment, you will miss language. Of course. So you can't rush to these diagnoses. You can't go in saying, I'm going to do an ADHD assessment, I'm going to do an autism assessment. You've got to assess the child, and that's the principle on which our clinic is based, is that we don't do assessments for diagnoses. We do assessments of children as an initial assessment. And then we will do some specific diagnostic work. And then, of course, you are giving medication which can cause harm. Both in the UK, that's mainly a concern in in ADHD. However, when I get children from overseas who come to Lambeth who have a diagnosis of autism, not infrequently they are on 3 different medications. They're often on an antipsychotic, an ADHD medication, and an antidepressant. And you take them, and all, actually, I mean, this is a generalisation, but generally speaking, what they need is a good special school. And once they get into a good special school, you can stop their medication, generally, because the family has coping again. And actually, sometimes you need to put a few other things in place. But generally speaking, the main thing they need is a decent school. Which is amazing, really, how many people... I mean, one of my favourite things is stopping medication. I also like removing diagnosis if I can, but it doesn't happen often. I'm not anti-diagnosis. I give a lot as well. It's nice to say, no, you haven't got this. I also want to make a point about underdiagnosis. So I want to just quickly tell a story, and I'm not anti-psychotherapy either, but I'm going to have a go at psychotherapists now. There was a lovely boy of a... Where's Mum from? Well, she's from London, but family's originally Ghanaian. And he was going to a school, a primary school. He's having a lot of trouble with behaviour. His communication is very poor. He's very angry a lot of the time. And the school had a kind of arrangement with the local Wandsworth Mental Health Service, and they had a psychotherapist come in. The psychotherapist interviewed Mum, and Mum said, "Oh yes, well, Dad's not around, and he did push me once, and we had a big argument, but this boy, M, wasn't there, so I don't think it's particularly relevant." But the psychotherapist got the idea that all of his behaviours was as a result of domestic violence, and that Mum wasn't telling him, Mum wasn't telling the therapist the extent of the domestic violence. And this was not an unreasonable therapeutic hypothesis. Initially. At the same time, I got involved and said, well, this guy might have a neurodevelopmental condition because he's quite pervasive and his behaviours are quite difficult and his communication is not great. Actually, it turns out his communication has matured and now he's very much outside the ASD spectrum, but his ADHD symptoms did persist. And for 2 years, I stayed involved on and off going, I really think I'm missing something here. And the school was like, no. And then there was a change of special needs coordinator. And she was like, yeah, I think there is something. And then the psychotherapist would come back in and say, no, this is what we're doing. And he got no better for 2 years of psychotherapy. No better. Until the contract with the Mental Health Trust ended, the psychotherapist left, and then the school went, now can you have a look? and we diagnosed. And he's doing much better. And it's not, this is all... I have a friend who's not medical, and he's like, your medical stories are just like every other work story, which is everything was going terribly, and then I came along and I sorted it all out. And it's true. All work stories are like that. And yes, that's true, my stories are often like that. And I could probably tell you lots of stories about I was messing things up and then someone else came and sorted it out. The point is, that's how we understand things. We understand this was wrong and now it's right. It conveys it better. If you stick with an alternative explanation, if you stick with that tunnel vision of this is why this behaviour is happening, you can make 2 problems. One is, behaviour is never just due to one thing. I'm not saying that M's behaviour is just because of his ADHD. It is also because of his rock bottom self-esteem. It's also because of his difficult relationship with his mother and his brother. It is quite possibly contributed to by his abandonment by his father. Yes, all of those things are true. But it's also contributed to by the fact that he has this kind of brain. All of this is happening in the background. Sometimes I talk about neurodevelopmental conditions as being the scenery for a play. They're not what's happening, they are the background against which it happens, and they condition what's happened. If you have the scenery for a play, it will constrain what is possible. And I think that's a reasonable analogy to draw here. There's also the unwillingness to label, which has already been raised, and which I think I've already dealt with. Labelling is human nature. Labelling is going to happen, so just do it scientifically, in my view. There is an aversion to medication, which I completely understand. But I think the solution to that in autism and ADHD, in all of these things, is to say, getting a diagnosis and making the decision to give medication are completely separate decisions. You can get a diagnosis of any of these things and live perfectly happily without medication if that's what you want or what your family decides to do. And then you don't have to worry about whether you want to diagnose or not. And then the question becomes a lot easier. And I think in the US, because medication is not everyone gets medication, but almost everyone gets medication in the US, it's made the debate around ADHD that much more feverish. And we can have a separate debate about medication and what the place of it is, but that's not really what I'm talking about today, unless you want to bring it up in questions. That's fine. The one thing that I think there is an element of is that either the parent or the child will use a diagnosis as an excuse. It's not my fault, I've got ADHD. He can't do anything about it. It's got the ADHD doctor, so I just can't do anything. That is not my... I know that there are... This is a difficult one, right? I know that there are colleagues who come across this a lot. I don't. I put it down to the fact that I work in Lambeth, and Lambeth people are completely awesome. I may be wrong about that. But it's very rare that I come across it in Lambeth. It may also be because, at the very beginning, I say, this thing about your brain makes some things more difficult, but nothing is impossible. You can still be Prime Minister. Because if that bloke can, then you will. So, I don't say that in Trinidad. You can still be Prime Minister, and there's no excuse for not trying. I'm not, and I look at the kid and I say, you're not using this as an excuse. You get that? And the first time we give the diagnosis, that's what I say. And obviously that's also a message to the family, but I don't point at the family, I don't point at the mother in the same way. But you just got to nip it in the bud, and then it generally doesn't. My experience is it doesn't happen after that. I think sometimes it happens when the family feel the school are not doing enough, and they're saying, well, he's got ADHD, what are you doing about the ADHD? You can't punish him, because the reason why he's fidgeting is he's got ADHD. That is a difficult issue and a complex issue. Sometimes my solution to it is, well, what are you doing about preventing it? If you're doing enough to prevent it, or to give other outlets to this child's energy, then yeah, if they're still disruptive, you can put some consequences in place. But if the school are not doing anything to prevent things, to head things off, then I think the school are on pretty shaky ground, just using the same kind of draconian measures. Our secondary schools are increasingly draconian about behaviour in the UK, and it is a big problem for both autism and ADHD kids. And actually, incidentally, the DCD kids as well, because they're so disorganised. Okay? Right. So, if you underdiagnose, you miss opportunities for intervention. Em is a good example of somebody who's missed basically 2 years of potential intervention to kind of get back on track educationally. Parents end up being endlessly blamed. So Em is another example. Mum was made to feel, whether or not it was deliberate, that the reason why he had problems is that she allowed herself to continue with a relationship which was abusive. And also, there was a suggestion that the end of the relationship was also her fault. You can't win, can you? And if you don't treat neurodevelopmental conditions, there's good evidence, fantastic work from Scandinavian countries looking at outcomes. If you don't treat these conditions, particularly ADHD is good evidence, but also the evidence that you intervene in the difficulties of autism. You don't have to make a diagnosis, but you've got to intervene in the communication difficulties and the interaction difficulties of autism. If you intervene early, you get better outcomes. So you're missing out on outcomes if you don't diagnose, sometimes. And also, you get exclusion. I've just put exclusion out there as a word, but of course it could mean school exclusion, it could mean social exclusion, it could mean exclusion from families, exclusion from activities. All of those things are true if you don't accurately assess the child's needs. Yeah?
These over and under diagnoses, could they be totally used now? Because there was a paper a few years ago about the different criteria from ICD-10 and DSM blaming the DSM that is too lenient nowadays, and you have more diagnoses based on this.
So, that moves on to my next slide. I don't think there's any such thing as the right prevalence. I think it's a discussion. I think it's almost a kind of. So I think that there's the DSM and the ICD are just words on a piece of paper. They're just, and what actually makes a difference is the culture of how people are trained to interpret those words. and also the perverse or otherwise incentives to diagnose or to not diagnose within the professional culture of the country. It is true that generally speaking, the DSM is a little looser, and where perhaps ICD would require you to have this symptom and that symptom in the DSM, it would be this symptom or this symptom, just broadly speaking. This isn't a lecture about the difference between ICD and DSM, because I've been to one of them and I fell asleep, and I love ADHD. I couldn't deal with that. Because it doesn't matter, really, because what you're dealing with is how much, what you're dealing with, the question is, to what extent has this person got this kind of hungry brain, this kind of ADHD, fizzy, hungry, but whirring brain, and is that causing them problems in their everyday life? And actually, I barely ever look at these criteria. I'm sorry, I apologise, but I don't look at them very often. I use the Conners as a proxy, in fairness, but that is the really key problem. Is the extent to which they're along this spectrum causing them a problem in a way that we can help? That is the real question here. Not do they fit the 5 or 6 categories in the DSM, or 8 or 9 in the ICD. That doesn't seem to me to be as important a question. Because the other thing about these criteria is that they all embed in a seemingly objective system. They embed subjectivity because it's all about language, and language is subjective. What is significant? What is disruptive? What isn't disruptive? It's all subjective. It's all subjective. That all said, this is a very interesting and good study looking at UK, actually using ICD criteria, and looking at the UK and the overall prevalence of ADHD and autism in boys and girls. So ADHD, if you average those two out, about 1.8. So just under 2%, which is international comparison is on the low side because ICD is a little bit more restrictive, and I'm comfortable with that. 2% of the population in the UK have ADHD. That means that ADHD still means something. It means that this is a special population that can be marked out as for special attention. So it means that there might not even be one in each classroom. If there's always if you go up to 10%, if you reduce your criteria so much that all of these guys get into the ADHD category, it stops meaning much, doesn't it? And actually people will stop caring about it. So there's something about cheapening the diagnosis, which I put up and talk about. Just as an aside, also you have autistic spectrum disorder. It's such a big disparity between male and female. I'm not sure I completely buy it. I suspect that they are being a little bit, they're using rather old, ancient tools that don't really pick up ASD in females very well. But this is obviously the place to get the best tools for that. But anyway, the point is, again, we're talking about just over 1% for autistic spectrum disorder. So I think that's a reasonable ballpark. And I think it's reasonable if you're running a service, and if you're not, if you're only diagnosing 0.5% of your population with ADHD, you're probably underdiagnosing, you're probably not picking up things. And it's probably not that they're coming to clinic and not getting a diagnosis, it's probably that they're not coming to clinic. And so you need to go out to the community, to schools and to GP surgeries and say, where are these kids? Even if your waiting list is miles long, you've still got to say, well, there is unmet need in the community, it's still important. So I think it's reasonable to take these figures and look at whether you're systematically over or underdiagnosing in your district. I think it's a reasonable thing to do. So these are my tentative conclusions, and having thought I was going to run massively under time, I've got a little bit of time for questions, but not as much as I thought. I would say, and I said already, we are assessing children, our young people. We're not assessing diagnosis. I really, really think that's important. If you have somebody who has above their clinic wall, this is the ADHD clinic, and they're doing initial assessments from the community, then they are going to overdiagnose ADHD. They are, because that's what they're looking for. If everything looks like, if all you've got is a hammer, everything looks like a nail, doesn't it? So diagnosis equally is a tool to be picked up when it's helpful and put down when it stops being helpful. So there are kids who have helpfully been diagnosed with autism, but they've matured and they've grown, and perhaps they're not quite in that ballpark anymore. There's nothing wrong with saying, your diagnosis of autism was fine. There's nothing wrong with it, but it doesn't fit you anymore and you don't need it anymore. Go forth. Be awesome. I've done that quite a few times with adolescent boys, particularly. And that's great. It's only of value in instrumental value. It's not got any value in itself. So although I defend diagnosis, you've got to get the context. If you look at the kids with ADHD, Richard Saul is right in that. You've got to change the context of the ADHD. You've got to modify this, because in the vast majority of your kids with ADHD, the environmental modification, first of all, there's no side effects, and second of all, it's actually going to make a big difference to their quality of life, as well as to the family's quality of life. And that's really what we're in the game for, isn't it? I reckon. And I think, if there are alternative perspectives, I've had a go at attachment theorists and I've had a go at psychotherapists, but they're still valid. I don't think that M didn't have any benefit from his psychotherapy. It wasn't enough on its own. So we've got to work together. There's nothing wrong with somebody concurrently having psychotherapy for another reason and also being treated for ADHD. There's nothing wrong with that. You don't have to just have this kind of territorial domain over patients, that they're this is my patient, it's a medical patient, this is a psychology patient. It doesn't make any sense. And so I really would guard against anything that smacks of that kind of territorial approach. This is a much more terrible photo than I thought it was. Never mind. Anyway, there's some ways of getting in touch with me if you're feeling shy and don't want to ask a question now. Otherwise, I am going to take some questions, or you could just go.
You've talked quite a lot about kind of making a diagnosis, a diagnosis. But I wonder what you thought about the granularity of diagnoses. So you see a lot of children who have a symptom from this syndrome, from that symptom.
Yeah.
Do you think, are you someone who would try and group those all together in one underlying diagnosis, or do you think a multiplicity is sometimes the way to go?
I think if you've got bits and bobs from all sorts of the plate, all over the place, I think it's difficult, because again you go back to whether a diagnosis is useful, and one of the main arguments for retaining diagnosis is to link it to an evidence base. So if you say somebody has ADHD, you've got a reasonable chance that the ADHD, the nice guidance for ADHD, if applied to that person, is going to help them. If you've got bits and bobs, I think making a diagnosis out of those bits and bobs doesn't lead you to any kind of evidence-based intervention. So it's much better then to do, you could call it a formulation. I love the word formulation, I love the concept of formulation. Or you can just profile, you can call it a developmental profile. It doesn't really matter what you call it. At that point, it's really important to take that kind of biopsychosocial approach that is another talk we could talk about. You guys are probably all on board with it. But the point is it's biopsychosocial. So the biological is really important, and the psychosocial, and see what we can actually do about it. And at that point, when you've got those bits and bobs, kids, you realise how much less important we are than the teachers and the youth workers and the children's centre workers who actually work with them day to day. That's the bottom line.
Thank you. It was a very interesting talk. So you talked about diagnosis within the context of the individual person. That gets a little complicated when you're doing research, from the research side of things.
Sure.
Particularly for a lot of the studies that we're running are online. So I was wondering what your thoughts are on the kind of online assessments and how research can then, if we're using these types of tools to diagnose our own participants, how that then can be useful when it's translated to
I had so many, I know. I mean, I love this place, and I love the research that comes out of it. But I've had so many kids come back with these. He's got a something phobia, and like, has he? Yeah, apparently. Oh, okay. Yes, it's fine. I think it's really important to distinguish between a research. Is it? I don't know. I think sometimes it's important to distinguish between a research diagnosis, which is we're going to put you in this category from the point of view is you're probably a bit like these people, versus a clinical diagnosis, which is I think this diagnosis is going to apply to you in a helpful way. So I think those are two different things you're doing. And I think if we confuse the two. I don't think we confuse the two by using research tools in clinical practice, which I'm not sure is a very good idea because it's not a very good use of time clinically, but that's another, and again, another debate.
But in terms of, so we never will feedback these types of diagnoses, but
Well,
in terms of
they find their way into reports and people read them and go, has he got that? And they come to me and they're like, oh, let's have a think.
But in terms of when you, if you're doing research and you're saying, okay, these people have ADHD, these people don't, but your tools don't quite match what the clinical presentation is. How can you then ensure that the finding, I guess it's a little bit more like a philosophical debate.
I don't know.
Okay.
If I knew that, I would probably be working here, wouldn't I? Yeah, it's a really interesting question, and I think we can only say that the evidence base generated by research topics like that will probably apply to this person who's in front of us, but they might not. They might not help at all. And so I think always, so to take one example, the effect size in research studies on medication is always higher than it is in practice. Because in practice you're dealing with a much more kind of gnarly and knobbly kind of group of people, I suppose.
This is kind of an ethical question, I guess.
All for that?
I mean, you mentioned environmental modifications and behavioral modifications and this and that, but those aren't necessarily easy.
Nope.
And if they were, people with high cholesterol wouldn't be taking statins; they'd be having good diets and exercising, right?
Very true.
So if you have two kids that are maybe in the same place on the distribution of their brain.
Absolutely. Should we put it back up? Go on.
One has a family situation that's
Yeah.
be able to help and compensate, and one doesn't.
I know, I like where you're
As
going.
a pediatrician, do you give the kid with a family that's not going to be able to help them with medication?
Yeah.
That might actually help them function better, or do you not because they're theoretically the same
So,
level?
exactly. So, do we have an inherent, because of the structure of our society, do we have, and the fact that kids who are poorer tend to go to schools that are less unsupportive, have families that are less able to cope with their behaviours, do we therefore have an inherent bias in the way so that kids of lower socioeconomic class get more diagnosis, get more medication? Yes, we do, and we demonstrably do give medication more to children of lower socioeconomic class. Honestly, this is why I'm also politically active, because you've got to be, if you actually understand the fact that so much of this is conditioned by the social behaviours, the social conditions in which families grow up. Both at a local level, you've got to push for better early intervention, better children's centres, and you've got to push for better support at perfectly bog standard comprehensives for behaviour. At a very much pre-diagnosis level, you've got to push for that support and push for the kind of understanding and intervention that you would be able to access if you had more money to be available for all. So that's why, but also at a national level, that's why you've got to campaign against inequality in your society, because it clinically makes sense. Which is why, as part of my work as the Health Improvement Officer for the Royal College of Paediatrics, is on inequality. And it all connects into this. Does that make sense? Does that answer make sense? It's a very good question. Any more?
I do have a question about these diagnoses where you talk about sometimes revising diagnoses. Do you have numbers about how many diagnoses are revised?
No, but I think there's studies looking particularly at the autistic spectrum, looking at the proportion of children who, as they grow up, come out of the diagnosable category. One of the difficulties is that I mean, I think it happens much more infrequently than it perhaps should scientifically. So I think it was Field who did a study, and it was something like 10% came out of the diagnostic category. So this idea that we used to say that autism is a lifelong neurodevelopmental condition is not true. It isn't. It's a mostly lifelong neurodevelopmental condition. There's probably a lot of kids who, if you actually reassess them, would not fulfil criteria. But they've got their education, health and care plan, they've got their funding, they do have genuine need. It's not that these kids end up being completely typical, they just end up with other things going on. They've got their need. Who's incentivized to change their diagnosis? No one. And eventually, they just forget about it. They just go, well, that doesn't really... When they get older, they just go, well, that doesn't really apply to me. I don't really believe that. And they get on with their life. So actually no one's been harmed either, generally. So it doesn't happen very often, is the answer.
You mentioned the psychosocial approach, and you said it excites you?
I wouldn't say that.
But then you also said that you like taking drugs away from people. So isn't that the bio side of...
So the biopsychosocial model is essentially just throwing it all together. Come one, come all. Biology is important, psychology is important, social factors are important, and we should all mash it all together, throw it all at the wall, and see what actually helps. Broadly speaking, I like taking drugs away from people where the drugs are not helping them, because it allows me to both be the clever doctor, which I enjoy, but also not reduce the risk of side effects and remove things that are harming children. It's a brilliant feeling. When the family wants them removed as well. I'm not so I suppose I'm doing lots of throwaway comments, but it's really nice to bring clarity to situations, but equally it's really nice to be able to take in the whole situation as a whole, to appreciate that situation as a whole, to not pick and choose what bits you think are important, just say, yes, like in M, for instance, yes, your social situation, your dad, everything's important, but so is your ADHD. They're both nice things to do as a doctor. That's the one thing.